Hello, my name is Debra R, and I am presenting to you today building a case for minimally invasive hemodynamic monitoring in various shock states. This was presented at the National Teaching Institute, NTI, with the AACN in Boston of 2018. So our objectives will be analyzing at least three types of shock and their characteristic hemodynamic profiles while differentiating between dynamic and static hemodynamic variables and each one of those strengths. So what is minimally invasive dynamic hemodynamic monitoring, or sometimes referred to as functional hemodynamics? Well, as you can see there on the screen, cardiac output, index, stroke volume, systemic vascular resistance. These can all be measured beat to beat in real time, meaning that as the patient is experiencing the changes in these parameters, you can also see them on a screen. And because of that, you can see an event response to an intervention such as a fluid bolus, titrating an inotrope, or perhaps a vasopressor, as the patient physiologically is experiencing it. Also, we can determine fluid responsiveness. Now, this is a very different parameter than does my patient need fluid. And the way we can measure fluid responsiveness is through stroke volume variation and or pulse pressure variation. Conceptually, these are exactly the same SVV and pulse pressure variation. They are just derived a little bit differently and are usually presented in a percentage. To get stroke volume variation or pulse pressure variation and to be sure that that measurement is valid, it does require your patient to be intubated on positive pressure ventilation, a regular heart rate, a tidal volume ideally of 8 cc's or per kilo, although there have been studies out that have shown validity with a patient ventilated at 6 cc's per kilo. You need a good A line, meaning it's not positional, it's reliable, a closed chest with a intact diaphragm. These are examples of calculated and static indices. Your static indices are shown here, blood pressure, CVP, and your pulmonary artery catheter numbers down there with RVSI, WI, and your pulmonary artery wedge pressure. These are static. These are snapshots in time. The measurement is taken, we turn, we put it in the computer, and then we sit back and go, well, what are we going to do with these numbers collectively, and how does it help us with our clinical picture? Where functional hemodynamics or dynamic measurements of hemodynamics are beat to beat. Now, for example, a blood pressure that is being derived from an A line is beat to beat because you see it as it's happening. And so that would be considered dynamic opposed to when you're doing with a cuff. So why is this important? And why is the calculated hemodynamic measurements, for example, SVR, is important for us at the bedside? Well, you need to consider that the numbers that are being put into the equation, for example, SVR requires an accurate cardiac output, MAP, and CVP. So if we're scratching our heads at the bedside going, what is going on with this SVR? I always go back and look at what is part of that equation, and it is the cardiac output, MAP, and CVP, which is part of the equation to come up with a systemic vascular resistance number. Is it representative of our patient? And we need to scrutinize these things at the bedside, especially if the numbers and the data do not match our clinical picture. Data is only as good as accurate as it is, or valid as it is. And so consider these things at the bedside when you are doing your patient care. This shows a diagram of functional hemodynamics or dynamic variables and how it works. And so what this technology does, it looks at the area under the curve of your A line, the red area there, up to the dicrotic notch, which is basically your stroke volume. And knowing stroke volume times your heart rate equals cardiac output. So it's a very easy equation that comes up onto the screen. But perhaps is more importantly about this notion of functional hemodynamics is that it is able to determine fluid responsiveness, meaning looking down here at this diagram over here, we're looking at where the patient is on the Frank-Starling curve, and we want to know, is our patient here? In other words, excuse me, if we give that patient fluid, will in fact they respond? Responding means increasing stroke volume. And so this is extremely helpful when we're fluid resuscitating, we're titrating medications or fluids or vasopressors or inotropes, is that we want to know that if we give fluid, they in fact will respond. This does not answer the question, does my patient need fluid? It doesn't answer it at all. In fact, there's 3 questions I ask when I go to the bedside. I first ask, well, is the patient perfusing adequately? Typically the answer is no. And then we go on to go, do they need fluid or do they need tone? Because both of which are components of blood pressure that create forward flow. Okay, so then we go, don't know. And then we think, okay, they need fluid, but will they respond to fluid, as in increasing stroke volume, if we give them that fluid? And that's what stroke volume variation or pulse pressure variation answers, that question, our responsiveness. So very, very important when we're in the throes of resuscitation to stay on this ascending area of the curve here of the Frank-Starling law, where we know we can increase our perfusion. This is another way of looking at how positive pressure ventilation affects the circulation of the blood as it goes through the pulmonary and cardiac vessels. And you can see here that during expiration there's a drop, and then inspiration it goes back up and down and back up again. This is the depth of this waveform is what we're really interested in that it can indicate to us if that as represented in a percentage, if that waveform is deeper than 13%, we know that most likely our patient will respond to fluid. Conversely, if the waveform is flatter, meaning that there isn't that much variation, such as with the blue line here, our patient most likely will not respond to fluid, and that is typically known as less than 10% variation. So this is what we're talking about, in essence, the relationship between pulse pressure variation and fluid responsiveness. And this is the Frank-Starling curve, which is I showed you earlier on the LICO screen. And what Otto Frank and his buddy Dr. Starling figured out was if, as we increase preload, which is typically assumed to be volume, you in fact will increase stroke volume, and that's what we want to do. We want to keep our stroke volume to help our patients continually perfuse adequately. And what we want to know, what's so cool about stroke volume variation or pulse pressure variation, which you can see there is indicated by greater than a 10 to 13% variation in the waveform, is we want to know when we're right here, right in this area. Because that area, we know if we give preload or increased tone or perhaps give the heart a little something with some inotrope, that we will continuously increase our stroke volume and therefore help our patients to adequately perfuse. How do we know with blood pressure and MAP and heart rate, and for those who are still holding on to CVP, and please be cautious when using a CVP because there's so many things that affect CVP that have nothing to do with volume. For a quick example, right-sided heart failure. How do you know when you're giving fluid or titrating or in the throes of resuscitation when you are right here? How do you know when, if you continue giving that fluid, that your patient will no longer respond? And this is indicated with stroke volume variation or pulse pressure variation by a waveform that is less than 10 to 13%, meaning the waveform is flattening. As I showed you earlier, it is an indication that if you give that patient fluid, in fact, that fluid is not going to increase stroke volume. And if this curve continued on, it would look just like this. And your stroke volume, ergo your cardiac output, will actually drop and drop dramatically. We have now taken a huge step backwards in our perfusing and our resuscitation efforts. And we, in fact, if we still continue to give fluid with a flattening stroke volume variation waveform, where does that fluid go? It typically goes to the lungs. We have now thrown, or could have thrown, our patient in pulmonary edema, which is a second or third hit that they did not have when they came into our hospital. And so what's so cool about this concept of functional hemodynamics is we can find out when we're right here, and we can start making better decisions on, whoa, if our patient is still not perfusing at this point, and they're no longer responding to fluid, what are our choices? Well, we have choices. We can give a vasopressor, we can give an inotrope, we can do alternative maneuvers besides give fluid and therefore do no harm. LiCO is extremely easy to hook up. You do need to put in the patient's demographics, for example, age, height, weight, that type of thing, so you can get a total body surface area if in fact you want to index your numbers. And then simply take the conduit cable from the LiCO and place it into your bedside monitor so LiCO can sense the A-line waveform and the heart rate, and therefore it can calculate your stroke volume. We were talking about shock today, and while there's many different types of shock, the bottom line is that we are simply not getting enough perfusion to the toes and back and to our end organs. And in the presence of anaerobic metabolism, our cells start to break down. We get cellular debris, which accelerates the profound effects of shock on our patients and directly affects outcomes. This is a chart of categories of shock, sometimes put in categories of hemorrhagic or non-hemorrhagic. Regardless, this is for your reference, and in the spirit of time, I'm not going to be going over all the physiological responses of different types of shock, but do keep in mind that shock is many times not in isolation, and a patient can be in 1, 2, or even 3 shocks at the same time. So let's do a case study. This is a 36-year-old female. She was found down. She was arousable. She is homeless. Her companion reported that she had nausea and vomiting and poor intake just for the last few days and denies that she's been using any drugs or alcohol. Her heart rate's 100. Her blood pressure is 80/30. Map there is 50. Her sats are 92 on 100% non-rebreather. Her skin is clammy, cool, no obvious signs of infection, blood and urine cultures have been set, and she codes. She codes right in the ED upon arrival. We do get return of spontaneous circulation. She's admitted directly to the ICU where she and has been intubated in the ED while she was coding with 2 18-gauge peripheral IV. So just knowing what we know there, what kind of shock do you suppose she's in? And if she is, why? And shocks aren't isolated. You can be in multiple shocks at the same time. So what do? She's now in the unit, and she has received an A-line, so we're using the arterial technology of LiCO. And basically from the conduit cable, it is picking up her heart rate and blood pressure as previously mentioned from the bedside monitor right there. But now, because it can look at her stroke volume, we have cardiac output, which is 5.8, reminding you all that 4 to 8 liters per minute is normal. Stroke volume is at 58, which is low. Low normal is 60 mils per minute. And then we have an SVR of 592, which indicates she's pretty vasodilated out, which is a bit concerning looking at her cardiac output. I would think it would have been a little higher since her heart really is not beating against any resistancy at all. So let's march it out. Is our patient perfusing adequately? No. Does our patient need fluid? Yes. Do you think our patient, if given fluid, will respond? Well, we have stroke volume variation down here. She meets the criteria to use that number that is valid. She's on more than 8 cc's per kilo. She has a closed chest. She has a regular heart rate. So we can trust this number. And it does. It indicates that she will respond to fluid. So that's what we do. Okay, so we give her a fluid bolus. We gave her a liter, and you can see that her blood pressure came up a bit and her heart rate is fine. But what's notable more to me is that her stroke volume right there went up to 66, which is over 10%. Okay, so there's a nice diagram on this side of the computer that you can use, and we know with or without stroke volume variation. Okay, if you can't use that because your patient doesn't meet criteria to be able to depend on that being a valid number, we know if we give a bolus and a patient increases their stroke volume by more than 10%, in fact, they are on this ascending part of the curve here. They are responsive to fluid. Thereby, they will increase their stroke volume, and stroke volume, of course, times heart rate is cardiac output. We go ahead and give her a 2nd liter bolus, and you can see there on the right, her cardiac output has come up really nice to 7.8 from originally 5.8 with the stroke volume down below there in the blue at 88. So we still need to ask the same questions, though. Is our patient adequately perfusing? Well, we also need to look at the patient. You know, sometimes we get wrapped up in these numbers and we forget to look at the person in the bed. And so, yeah, we got to look at urine output or mental status or skin color or skin temperature. We really don't know very much about this patient. Interestingly enough, her stroke volume variation now is down from 12% from 23%. So what does that mean? That means that positive ventilation waveform is flattening. It means she is becoming less responsive to fluid. Okay, well, that's fine. We still need to ask the question, is our patient adequately perfusing? Do we think she needs fluid? If so, will she respond to fluid? Well, according to this, and let's say clinically she's looking fairly sound, we would say no. What would you do with this patient at this stage? So before we go on to the second case study, the previous patient did not receive any vasopressors to increase her tone. She continued to respond to fluid and did quite well and was profoundly hypovolemic due to her flu-like symptoms and was discharged within a couple days of admission. Okay, so let's take a look at this young 18-year-old man who was unrestrained driver in a motor vehicle crash. His head did star the windshield. This is an important thing to keep in mind. I work at a level 1 trauma center, so I see that, and you have to assume some sort of head injury, perhaps a cervical injury, and which is helpful when we're considering different shocks on mechanism injury. His blood pressure is 70/40, his heart rate's 38, shallow breathing of 10. He is unresponsive to pain. His skin is warm and dry. He's been intubated. He has 2 peripheral IVs. We triage him quickly to CAT scan, where it is negative for a bleed, fortunately for him. However, we do know that many negative CAT scans do not rule out a head injury. So knowing what we know, mechanism of injury, and how he presents, what kind of shock do you think this young man is in? So we get Litco on him, and you can see there his blood pressure is 70/40, his heart rate is 38, his cardiac output is 2.3, stroke volume is 60, and his SVR is 573 in the green box. So let's march it out. Is he perfusing adequately? No. Does he need volume? Yes. Will he respond to volume? Yes, according to our stroke volume variation of 22%. Everything we see here, we know he will respond. So, are you suspicious of a certain shock yet, given his mechanism of injury? So at the end of his second bolus, you can see here that his heart rate has come up a little bit to 42. His blood pressure, his MAP is still 54. His cardiac index is 3.4 with a stroke volume of 80. So we've got slight improvement, but not really a whole lot. Of course, there's also concerns there may be something else going on with this young man internally that we haven't diagnosed yet. Still, we got a stroke volume variation of 18%. And we still need to ask, is he perfusing? Well, pretty much we doubt it with a MAP of 54. Even if he is in super good shape, he could be having a baseline heart rate of 42. But I doubt that given his MAP is 54, it's below what we would consider adequately perfusing. At the completion of a second bolus, you can see that basically nothing has moved. His cardiac output is still 3.4. His stroke volume is still 80. His MAP still remains below what we would consider adequate perfusing. Mean arterial pressure at 56. His heart rate is still low. So we have to start thinking about why is this going on with this patient. And given his mechanism of injury, with a high suspicion of a cervical injury, that he is in neurogenic shock, which typically presents with hypotension and bradycardia in the context of an injury such as what he has sustained. And the problem with neurogenic shock is what? We do not have the brain working for us. Our sympathetic nervous system is not being activated to create tone. Our parasympathetic nervous system is not being blocked, which typically will cause the heart rate to rise. And therefore, it is dependent on us to keep him tanked and keep his forward flow going and keep his heart pumping enough until that shock can subside. Now, additionally, we have a stroke volume variation down here of 13%, and we're getting onto the area of the curve that says, ooh, he's not going to be so responsive to fluid. Yet we know he's not perfusing. So what are we going to do? What would you do? With the feeling we had him adequately tanked, we started a vasopressor because we knew that he needed to have that increased tone. And you can see by his numbers that he responded, thankfully, really nicely with an increase of his cardiac output. More importantly, with his increase of cardiac output in relativity to his SVR, which has also gone up from the vasopressor. A lot of times as SVR goes up, and if you have a sick heart, your cardiac output will go down because it's working harder against that resistancy. But this is a young guy, healthy kid, and you can see his heart obviously is healthy, and it's coming up very nicely. His stroke volume didn't increase all that much. However, bottom line, his cardiac output went up with his heart rate coming up, and his blood pressure is a bit better. Stroke volume variation still remains at 13%, which is fine, but we're really interested in looking at the whole picture globally, making sure that we are increasing his perfusion to buy him time for the shock to run its course and work him up for any other subsequent injuries he could have sustained. Our third case study is a previously healthy woman who comes into us postoperatively to our ICU from a debridement of her right upper extremity related to necrotizing soft tissue infection. This is an extremely aggressive bacterium that is life-threatening. Many times it requires amputation or even disarticulation of a limb simply to save the patient's life. And so this is a very sick woman. We have fluids going. She is on an antibiotic protocol, per protocol. Yes, this woman is, what do you think? Yeah, she is septic and probably in septic shock. She's cool and clammy. She's not reversing from her agents from the OR. Her white blood count is 22,000, and her lactate is 612 and now 16 post-op, which is an indication that condition is worsening and that in fact we may have not gotten source control in the OR. So here we go. These are initial measurements on LICO. She does have an A-line, so we can use again the same technology. And you can see there, and we're like, well, is she compensating? She's trying to. Her heart rate's going a mile a minute, 132. She clearly has a healthy heart, and that's the only reason that she has a cardiac output of 7.6 here, with a stroke volume of 58, which is a little low, and way vasodilated out with an SVR of 609, which is another indication of sepsis, and in this case, shock, because whatever we're doing is not working yet. Her stroke volume variation is 24%, which indicates what? It indicates if we think she needs fluid, she will in fact respond to fluid by an increased stroke volume. We do a passive leg raise. Why not? There's no contraindications to doing a passive leg raise. Very concerned that the shock is winning and that our patient is already profoundly ill and is in a life-threatening situation. This is the schematic that is on the right side of the screen for you all to guide you through the passive leg raise. And basically you're raising the legs up to about 45 degrees for over a minute or so. And what you're looking for is if the stroke volume increases by more than 10%. You can also do this with a fluid bolus. In the absence of having stroke volume variation, you want to know, or pulse pressure variation, you want to know if your patient can respond. You can still hook this up and do a passive leg raise. It's still measuring stroke volume, and it still can measure cardiac output. And if the stroke volume goes up by more than 10%, you can assure yourself that the patient will respond to fluid as indicated by increasing that stroke volume. And she did. She went from 58 to 64 stroke volume. So that's good to know. And we probably gave her about a 200 cc. It kind of depends on what you read and the size of the patient. 150 to 250, 275-ish cc's of fluid. You can bolus from 2 lower legs into the central circulation. So this was a good thing. At least she's responding a little bit to that. Still vasodilated out. We go ahead and give her 1 and 2 liters of fluid. And I apologize to the cardiac nurses out there. I know that sounds like a hideous amount of fluid. And you can see here on the screen that her heart rate's come down to about 110. Her cardiac output is now 7.2, slightly improved. And her stroke volume is 66 right here. And what is helpful about that is on the right side of the screen here, there's the schematic reminding you in the absence of having the measurement of stroke volume variation or pulse pressure variation, and you don't know if your patient's going to respond to fluid, you can give a challenge. And if they respond by 10%, you know that, wow, they're great. They're right there on the ascending part of the curve, exactly similar to doing a passive leg raise. So let's see how our patient's doing. Do you think she's perfusing adequately? Well, I can add to you that her stroke volume variation is 10%. She is becoming, her lower extremities are looking mottled. She is cold. Her oxygenation demands are going up on the vent. All indicators that she is not perfusing adequately, yet according to stroke volume variation of 10%, she has not responded to fluid. So in the absence of proper perfusion, and she's on now this part of the curve over here, what are we going to do? She responds immediately to vasopressor, and this is the neat thing about functional hemodynamics versus static indices, is that we are seeing this immediately. Her cardiac output goes up immediately to 8.0. Her SVR is about the same, around 800, but her forward flow is increasing. Her stroke volume is now at 70. We are getting more forward flow. This is a really good thing. Her heartbeat is about 115. Her blood pressure has come up. And so the physician says, oh, she's responding so well, and she responded so well to fluids, let's give her fluid. Well, where do you think she's on that curve? Is she on the top flat of that Frank-Starling curve, or is she on the ascending part of the curve? And we're trying to convince him that maybe we should just let her be for a little while, but instead we give her a 500 cc bolus, not a liter. We gave her 500 cc's, and what happened was her cardiac output dumped. It went from 8 to 5 because we are now giving her fluid that is no longer increasing her forward flow, and it's probably going into her lungs. Therefore, knowing your stroke volume variation in context with answering the question if your patient needs fluid is extremely important. And this is how this technology can help us be much more exacting and precise when resuscitating our patients without doing harm by giving too much fluid. So once again, looking at the Frank-Starling curve, what we want to do is know when we're here. We want to know when we can increase stroke volume. We want to answer the question first, is our patient perfusing? Second, do they need fluid? Do they need forward flow? Do they need tone to get that forward flow? If the answer is yes, then we go ahead and give fluid. However, we also need to know where they are on this curve. Will they respond to fluid? If they are in this area, that's wonderful. We can give fluid. However, if they're in the non-responsive area, which would be a low, less than 10% pulse pressure variation or stroke volume variation, and we're concerned about their perfusion, this would be an indicator to start vasopressors, which could create tone and therefore forward flow. So today we went over neurogenic shock, hypovolemia, and septic shock, and hopefully you have started to understand the benefits of functional hemodynamics, which are basically measurements that are happening in real time to help us when we're titrating or we're toning someone up or we're in the throes of resuscitation. Certainly, though, what trumps any type of technology at the bedside is you and your clinical judgment and your assessment of your patient. Thank you so very much.